What the Study Says.
Welcome back to What the Study Says. I'm Dr. Kai.
And I'm Dr. May. Today we are doing a deep dive into a topic that, well, honestly, it completely dismantled a lot of the assumptions I had.
Oh, absolutely. If you're listening right now and you hear type 1 diabetes and immediately just picture, a 7-year-old in a pediatric clinic, you are exactly who needs to hear this.
Precisely, because we are looking at a brand new review article. It's hot off the presses from February 16th, 2026.
Published in JAMA.
Right in JAMA. It's titled simply Type 1 Diabetes, a Review. And it's by Dr. Laura Jacobson and Dr. Desmond Schatz down at the University of Florida. And right out of the gate, the epidemiology they present is just startling.
It completely flips the narrative we've been taught. I mean, we have spent decades calling this juvenile diabetes. But the data from this 2026 review shows the median age of diagnosis in the U.S. is actually 24 years old.
24?
Yeah, 24.
That is just wild to me. That means for every diagnosis we see in a children's hospital, there is a young adult trying to navigate this while, finishing grad school or starting their first real job.
Exactly. And globally, it's even older. The worldwide median age is 29.
Wow.
And the implications there for misdiagnoses are just massive.
Yeah.
Because if you're a general practitioner and a 30-year-old walks into your clinic with high blood sugar, your reflex is probably going to be...
You've got type 2. Lose some weight, take some metformin.
Right. And if that patient actually has type 1, that advice isn't just wrong, it is actively dangerous.
Yeah, we are definitely going to get into those diagnostic pitfalls in a bit, but I want to linger on the why for a second, because this review highlights something that almost sounds like an old wives' tale, but it's statistically robust.
The seasonality aspect.
Yes, the seasonality. Diagnoses consistently spike in the fall and winter months.
Which is one of the strangest consistent findings in this field.
It really is, and it immediately points the finger at environmental triggers, right? Like specifically viral infection.
Yeah, because we know viral loads are higher in colder months. It suggests this sort of hit-and-run mechanism where a virus, maybe an enterovirus or Coxsackie, riles up the immune system.
And in all that immunological confusion, the beta cells in the pancreas just become collateral damage.
Exactly. It reinforces that type 1 isn't purely genetic, it's an interaction.
Yeah.
You have the genetic loaded guns, specifically those HLA, DR3, and DR4 genotypes, but the environment is what actually pulls the trigger.
And speaking of genetics, I think we need to bust the family history myth while we're at it, because I vividly remember learning this back in med school and being completely shocked.
Oh, the 85% statistic.
Yeah, the 2026 data completely backs it up. 85% of newly diagnosed patients have absolute no first-degree relative with the disease.
And that is the stat that just floors parents in the clinic. They say, nobody in our family is this. How on earth did this happen?
Right.
But the reality is that while familial clustering does happen, it is the exception. It's not the rule.
Right.
The genetic susceptibility is actually pretty widespread in the general population, but the autoimmune event itself is sporadic.
So let's talk about the mechanics of that event. And I know we usually avoid the whole insulin as a key metaphor, but I think for a quick refresher, it's helpful here.
Sure, it's a classic for a reason.
Basically, you have your pancreas. Inside the pancreas are these islets of Langerhans, which contain beta cells. And those beta cells produce insulin.
And insulin is the key that unlocks your body's cells so that sugar from your blood can actually get inside and provide energy.
Right. Without that key, the sugar just builds up in the blood, which is hyperglycemia, while the cells themselves are literally starving.
But in type 1, this isn't a problem of insulin resistance like in type 2. This is T-cell mediated destruction. The immune system flags beta cell proteins, sometimes insulin itself, or an enzyme called GAD65 as foreign invaders.
So CD4 and CD8 T cells infiltrate those islets and systematically wipe out the insulin factory.
Exactly. And this brings us to one of the most critical conceptual shifts in the JAMA review, the staging system.
Yes, this is huge. We used to treat type 1 diabetes as this binary switch, right? You don't have it, and then suddenly you do.
Right. But we now understand it's a continuum. There's a silent countdown happening long before the first symptom.
So walk us through that. Stage 1.
So stage 1 is the completely silent phase. This is when a person has 2 or more autoantibodies present in their blood. Their immune system is actively attacking the beta cells, but they still have enough reserve capacity that their blood sugar is totally normal.
They feel fine. They look fine.
Exactly.
But physiologically speaking, the fire has already started in the house.
That's a great way to put it. And then they eventually hit stage 2. The beta cell mass drops enough that you start seeing dysglycemia.
Meaning their fasting sugars might still look okay, but if you gave them an oral glucose tolerance test, they would fail it.
Precisely. The body has effectively lost its ability to handle a sudden surge of sugar, but they still usually don't have obvious symptoms.
Which leads us to stage 3, what we historically just called diagnosis.
The clinical phase. The remaining beta cells are completely overwhelmed, hyperglycemia sets in full force, and you get the classic symptoms.
The famous 4 Ts. I feel like we recite these in our sleep, but they are missed so constantly in primary care.
They are missed because they can be nonspecific if you aren't actively looking for the pattern. So the 4 Ts. Toilet thirsty, thinner, and tired.
Polyuria, the toilet part, is really the driver here. Once blood glucose crosses the renal threshold, which is usually around 180 milligrams per deciliter, the kidneys just can't reabsorb it all.
Right, so they start dumping the excess glucose into the urine to try and protect the body.
And glucose is an osmotic diuretic. It drags a ton of water out with it, so you lose massive fluid volume.
Which directly drives the second T thirsty, polydipsia. You have patients drinking liters and liters of water, but they're still clinically severely dehydrated.
And then the thinner aspect. This is what usually brings the adults into the clinic, honestly. Unintentional rapid weight loss.
Because it's profound catabolism. Without insulin, the body cannot utilize glucose for fuel at all, so it shifts into starvation mode. It starts breaking down adipose tissue and muscle just to get energy.
You're eating constantly, but you are wasting away because you're metabolically starving to death.
It's terrifying. And this catabolic state is the prelude to the ultimate emergency, which is DKA, diabetic ketoacidosis.
And the review notes something really depressing here. Despite all our awareness campaigns, roughly 34% of children present in DKA at their initial diagnosis.
Yeah, that number represents a massive failure in our healthcare system. It means 1 in 3 kids is practically at death's door before we figure out what's wrong.
DKA happens when that fat breakdown we just talked about goes into overdrive. It produces ketone bodies, which are acidic, so the blood pH drops dangerously low.
You'll see Kussmaul respirations, those really deep, rapid breaths, as the body desperately tries to blow off CO2 to compensate for the acid.
You get the classic fruity breath, nausea, vomiting.
And confusion or lethargy. And honestly, it mimics a severe flu or a stomach bug, which is exactly why it gets missed so often in that fall and winter window we mentioned earlier.
Oh, absolutely. Parents think it's just a bad winter virus, but the child is actually in total metabolic collapse.
So how do we stop missing it? The review puts a huge emphasis on proper diagnostic tools. Obviously, we check fasting glucose and HbA1c, but to distinguish type 1 from type 2, especially in that median 24-year-old patient, you have to look at C-peptide.
Yeah, C-peptide is the absolute gold standard for assessing endogenous insulin production because insulin is synthesized as a pro-hormone, right? Pro-insulin.
Right, and then it gets cleaved into insulin and C-peptide in a perfect 1-to-1 ratio before it's released.
But the trick is you can't just easily check insulin levels directly in the blood. The liver clears insulin incredibly fast. Its half-life is something like 5 minutes.
Exactly. But C-peptide hangs around in the bloodstream for about 30 minutes, so it's a much more stable, reliable marker.
So if you have a patient with very high blood sugar, but their C-peptide is low or undetectable, that is type 1, the factory shut down.
But if they have high sugar and high C-peptide, it's likely type 2. The factory is actually working overtime, but the body is resisting the product.
We also can't ignore LADA here, latent autoimmune diabetes in adults. The review specifically touches on this as a major confounding factor in adult diagnoses.
LADA is essentially type 1 in slow motion. These patients have the autoantibodies, usually GAD65, but the autoimmune destruction is much slower.
They might not even need insulin for 6 months or a year after they are diagnosed.
Right, and because of their age, they often get misdiagnosed as type 2. They get put on oral meds like sulfonylureas, which actually forces the remaining beta cells to work harder and burns them out even faster.
So the major takeaway for clinicians listening to this deep dive, screen for antibodies. If you have a lean adult with hyperglycemia or anyone presenting with rapid unexplained weight loss, do not just assume type 2.
Check the GAD65. Check the zinc transporter 8.
It changes the entire treatment plan because, as this 2026 review makes very clear, the treatment landscape has evolved incredibly fast. But the core rule remains the same. You must replace the hormone.
Insulin is non-negotiable for type 1. Lifelong. No pills alone can fix this yet.
So patients usually need a basal insulin, which is the background coverage, and a bolus insulin for mealtimes. But the way we actually deliver that insulin has practically become science fiction compared to even 20 years ago.
It really has. The review is very bullish on Aid Systems' automated insulin delivery. It calls them the current standard of care, which aligns with the ADA 2025 guidelines.
An aid system or a hybrid closed loop has three parts right: the pump, the continuous glucose monitor or CGM, and the algorithm connecting them via Bluetooth.
Yeah, and I know you love the tech side of this. So let's talk about the CGMs for a second, because the data in the review shows these aren't just convenient, they're actual clinical game changers.
Oh, I completely geek out on this. A CGM is a sensor worn on the body for 7 to 15 days, and it measures interstitial fluid glucose every 1 to 5 minutes.
Which gives you roughly 288 data points a day, compared to the 4 or 5 you'd get from traditional finger pricks.
You are watching the whole movie instead of just looking at a few blurry photographs.
And the outcome data absolutely reflects that. The review cites that CGMs reduce HbA1c by about 0.4%, which is significant clinically. But more importantly, there is a massive reduction in severe hypoglycemia.
Because going low is the immediate danger.
It's the biggest psychological burden for patients. The fear of dropping dangerously low, especially while sleeping. Aid systems automatically shut off insulin delivery when the algorithm predicts a downward trend.
It's a safety net that lets patients and their parents actually sleep through the night.
Which brings up the concept of time and range. It really seems to be replacing A1C as the primary metric of success in the clinic now.
Makes sense. A1C is just an average. You can have a mathematically great A1C, but achieve it by having terrible highs and terrifying lows that just average out.
Exactly. Time and range tells you how stable the patient's blood sugar actually is. The goal is to spend at least 70% of the time between 70 and 180 milligrams per deciliter.
And aid systems make that genuinely achievable for people who struggled for decades.
Now, what about adjunctive therapies? Because I feel like lately, every week, I see a new headline about using GLP-1 agonists.
Yeah.
The Ozempics and Mounjaros in type 1 diabetes.
There is huge interest there, especially because the general obesity epidemic is absolutely affecting the type 1 population as well. But the JAMA review is pretty cautious on this front.
Currently, the only FDA-approved non-insulin drug specifically for type 1 is pramlintide.
But it's rarely used in practice.
Very rarely. The side effect profile is just too rough for most people.
Mostly severe nausea,
Yeah,
right?
severe nausea. Now, clinicians are definitely using drugs like metformin and GLP-1s off-label to help with insulin resistance and weight control in type 1 patients. And SGLT2 inhibitors are also very effective at lowering glucose.
But we have to mention the black box warning on SGLT2s for type 1. It is critical.
Euglycemic decay.
Yes. It is a terrifying clinical paradox.
So SGLT2 inhibitors work by causing the kidneys to excrete sugar into the urine, which means your blood glucose reading looks absolutely perfect. It might say 110.
But metabolically, because your sugar is artificially low, you might have dropped your insulin dose too much. And without enough insulin, the body enters ketosis.
So you end up with a patient in full-blown ketoacidosis. They are vomiting, their blood is dangerously acidic, but their CGM or glucometer says their blood sugar is completely normal.
And because the number is normal, they don't take any correction insulin. And an ER doctor who isn't familiar with euglycemic DKA might completely miss the diagnosis.
It requires an incredibly high degree of vigilance.
Okay, let's shift gears to what is arguably the most exciting part of this entire 2026 review: prevention.
Yes. For the first time in medical history, we aren't just reacting to the symptoms. We are actively interfering with the underlying autoimmune process.
We are talking about Teplizumab. This is the absolute headline of the decade. It's an anti-CD3 monoclonal antibody. Break down the mechanism for us.
So it targets those exact T cells we talked about earlier, the ones aggressively attacking the pancreas. It essentially exhausts or deactivates those specific effector T cells while preserving the helpful regulatory T cells.
It's like it hits the reset button on the immune balance.
Exactly. And the clinical data they highlight is specific to stage 2 type 1 diabetes.
Right, so they are approved for people who have the autoantibodies and the dysglycemia, but they haven't progressed to full clinical symptoms or insulin dependence yet.
And a single 14-day course of infusions can delay the onset of stage 3 by a median of 2 full years.
Now, 2 years might just sound like a blip to a statistician, but to a 12-year-old child, that is 2 years without daily injections. 2 years without having to carb count every single almond you eat.
It's 2 extra years of a normal adolescence. It is monumental.
And for some patients in the trials, the delay was actually much longer than 2 years.
Which proves the point that this autoimmune process isn't just an unstoppable freight train. It can actually be derailed.
And there's always a but with these things, this entirely relies on finding the people who are in stage 2.
Which brings us right back to the massive public health challenge of screening. You cannot treat what you do not diagnose.
General population screening still isn't the standard, though. Groups like TrialNet are definitely pushing for it. But the review strongly recommends, at a minimum screening, all first-degree relatives of current type 1 patients.
Even though the lifetime risk is only roughly 6% for a sibling.
Right, but 6% is 15 times higher than the general population risk, which is around 0.4%. It's our highest yield group.
If we screen them, we catch them in stage 1 or stage 2. And even if they don't end up getting Teplizumab, just having them in a monitoring program virtually eliminates the risk of them presenting in DKA at diagnosis.
Because you catch the blood sugar rising weeks or months before they crash into a crisis.
Exactly. You turn a life-threatening helicopter ride to the ER into a calmly scheduled clinic appointment to start basal insulin.
And avoiding that initial DKA prevents so much long-term cognitive and organ damage.
Speaking of long-term damage, the review closes by looking at the classic complications: retinopathy, nephropathy, cardiovascular disease. It's really heavy stuff to discuss with patients.
It is, but the trend line in 2026 is incredibly optimistic.
It really is. We always have to look back at the DCCT study, the Diabetes Control and Complications Trial. It definitively proved that intensive glycemic control, keeping that A1C below 7%, reduces the risk of eye damage by 76%.
And kidney damage by 50%. And now with the widespread use of aid systems, intensive control is becoming the default rather than the exception.
Which means we are seeing the gap in life expectancy finally close. Historically, type 1 diabetes shaved 10 to 15 years off a person's life.
But now with early diagnosis and this incredible modern tech, that gap has narrowed to about 8 years. And for patients with optimal control, it may be completely negligible moving forward.
It really feels like we are living through a major transition period. We are moving from merely managing a chronic disease to actively modifying it.
Absolutely. The combination of better analog insulins, automated delivery algorithms, and now immunotherapy means the lived experience of getting diagnosed in 2026 is radically different from getting diagnosed in 2006.
So to wrap up this deep dive, let's just synthesize the big takeaways for everyone listening. First, the demographics are shifting. This is not just a childhood disease, it is heavily a young adult disease with a median diagnostic age of 24 in the U.S.
Second, the physiology is a staged continuum. It's a progressive autoimmune attack, not a sudden overnight event. And that gives us a vital window of opportunity for intervention.
Third, technology has officially become the standard of care.
Right.
If you were trying to manage type 1 without a CGM and a pump algorithm in 2026, you're basically fighting with one hand tied behind your back.
And finally, prevention is no longer a pipe dream. With agents like Teplizumab, we have crossed the threshold into disease-modifying therapies.
Now, before we sign off, I want to leave everyone with a thought that has been kind of nagging at me since we first read this JAMA source material.
Yeah, what is it?
We talked about the seasonality early on, the winter spikes, the viral triggers. It really suggests that our environment is in this constant dynamic dialogue with our immune system.
A dialogue that honestly seems to be getting a lot more heated lately.
Right. If a completely common cold virus in December can confuse a person's immune system enough to permanently destroy a vital organ, and we know autoantibody rates are rising globally, do we need to start viewing autoimmune diabetes differently?
Like not just as a random genetic accident, but as a byproduct of our modern biological environment.
Are we somehow creating the perfect storm for our own immune systems to turn on us?
That is a very uncomfortable question. We might be doing an amazing job solving the treatment side of the equation, but we are still chasing the root cause of why this is happening more frequently in the first place.
Definitely something to chew on as we head into the winter months ourselves.
For sure. If you found this deep dive into the 2026 JAMA review insightful, please make sure you subscribe to what the study says.
And if you have a colleague or a friend who still casually calls it juvenile diabetes, maybe just quietly forward this deep dive to them. You might honestly save them from making a critical misdiagnosis.
See you in the next study.